Hi, everybody. This is Nicole Desar, and I'm one of the instructional coaches at Student Growth Center. And Leanne asked me to talk to you all today about physical disabilities for a couple of reasons. I think first, because I taught students with moderate to severe disabilities for 10 years in public schools, and many of them had one form or another of physical disabilities. And also, I have two children with physical disabilities. So, I think that I kind of deal with this stuff a lot and am used to explaining things to people. The word plegia. Plegia basically means paralysis. You'll hear hemiplegia, which means, even though we know that there are upper and lower hemispheres as well, generally if you hear hemiplegia, someone is paralyzed on one side of the body, the left or the right side. You'll hear quadriplegia. Quad means four, so all four limbs are affected by the paralysis. With quadriplegia, frequently the chest is also involved. If the chest is involved, those people usually need a respirator to help them breathe. There is paraplegia, para meaning two, that involves two limbs, almost always the legs. And finally, you'll still hear semiplegia. And semiplegia means that somebody might not be fully paralyzed. They may have some use of their hand or arm or leg, but they're not as useful as they can be. They either, maybe they can move it, but they don't have any grip at the end. Maybe they don't have good sensation. Maybe their brain doesn't process well because of an injury of some sort and they forget they have it and have to be reminded to use that. But there's lots of reasons that you would hear, especially in particular hemiplegia. You hear a lot, which means that they neglect one side of the body, whether because it doesn't work or because the brain doesn't process it correctly. When we talk about people who have disabilities in tone, we usually talk in terms of high tone and low tone. High tone means their muscles are too stiff. Their bodies can be rigid. It can be difficult for them to stay in proper seating position. It can be hard for them to put on clothes because they're sort of stuck in this stiff and rigid position. Certainly difficult to get them in a chair. Certainly difficult to sit on a toilet. Some of the things that we expect students to do at school are very difficult if their bodies are very rigid. That's high tone. Low tone is the opposite of that. Rather than being very rigid, the muscles are very loose, pretty weak usually. Students with high tone, by the way, I forgot to mention this a second ago, students with very high tone burn a lot of calories because those muscles are flexed all the time. So it's really hard to keep weight on kids who have very high tone, and sometimes they need some supplemental nutrition just because their body is constantly burning up calories. Children with low tone can actually be the opposite. They can have trouble with weight because their bodies wear out quickly. It's hard for them to move around. They're working harder than others. And because it's so hard for them to move around, they don't exercise as much. Also, you'll find sometimes in children with low tone who are weaker and floppier that we need to be very careful that they don't get heavy, because the heavier they are, the harder it is to move their bodies around with these weaker and looser muscles and looser joints. Another precaution to think of when you have a child with low tone is their joints, your muscles hold your joints in place. Children with low tone dislocate joints very easily. Be very careful as you move someone with low tone that you're not moving them by holding on to a limb, an arm, a leg, because it's very easy to pull something out of socket. And also, if you have a student who has low tone and they have a fall or they just are limping around and they're complaining of some pain, ask their parents to have it looked out, because they can suffer from dislocations because of that low tone. We want to make sure that kids are always safe. In addition to just standard high and low tone, there are two other major types of tone issues. There is mixed tone, where a student is stiff in one part of their body and loose in another part of their body. It can be either way. So you can have high tone in your arms and legs and low tone through your core, which means that even though it's kind of hard for you to hold up your head and hold up your body in good position, your arms and legs want to be stiff, and they are sometimes hard to bend and get them to do what you want to do. You can also have the opposite. You can have a very rigid core and very floppy arms and legs. Very low tone through those, and that again causes mobility and use issues. The final major category with tone is fluctuating tone. Sometimes we call fluctuating tone spasticity. An old term that you used to hear would be spastic quadriplegia. We really are moving away from that tone because unfortunately our culture likes to pick up words from the disability community and use them to describe things that are not disabilities and in ugly ways. So lots of people do not want to be called spastic anymore. They would rather be called someone who has CP with spasticity or fluctuating tone. All that means is that their tone can change, and it can change very rapidly. You could be moving somebody who's nice and loose, and you're moving them from one position to another, from one piece of equipment to another, and all of a sudden their body becomes very rigid. It can go the other way as well. Someone can be very rigid, and while you're moving them, all of a sudden their body goes limp. These students, mark it down, don't lift them alone. Have two people do transfers for students with fluctuating tone if they can't transfer themselves. If they can transfer themselves, stand there, be there to help them if they run into problems. If they can't, have two people do it all the time, because you never want to be moving someone, have their tone change, and them slip right out of your hands. If two people are there are two people to take up that weight that feels like all of a sudden you feel like you've doubled the person's weight because they're no longer supporting any weight on their own. Two people are much less likely to drop that person. Two people are much less likely to get hurt because they use their body to keep from dropping that person. Likewise, two people lifting someone who all of a sudden goes rigid, there's 4 hands there to help protect body parts that might be flying, to keep them from bumping into something, to keep them from kicking something over and hurting their body that way. So it's very important to use two people transfers if you have to transfer someone with fluctuating tone. So now that we've talked about tone, we might as well slip on in and talk about cerebral palsy as well. Cerebral palsy is one of the most common kinds of physical disability. It comes in a very, very wide spectrum. There are people with cerebral palsy that you might not even know that they had cerebral palsy. There are people with cerebral palsy that wear braces on their legs, but they're pretty daggone mobile. They can do and it only affects their legs. And there are people with cerebral palsy who are completely wheelchair bound, who are unable to eat, who are unable to speak. And so there is a huge spectrum. Cerebral palsy is caused by a brain injury during gestation or at the time of birth. Anything that happens after a child is completely out of the womb and birth canal is a brain injury. But if it happens prior to birth or during the birthing process, that is cerebral palsy. It is most often probably happens when a child loses oxygen at some point during the birthing process, whether a cord gets wrapped around their neck or for whatever reason they're in the birth canal and delivery slows down or stops and they go for a time without oxygen. That causes cerebral palsy. Another common physical disability that you might see in your room is spina bifida. Spina bifida is a neural tube disorder. It is caused by during the prenatal development, part of the spinal column doesn't completely close. When it doesn't completely close, what the opening fills with cerebrospinal fluid, and that's called a meningocele. A meningocele may not be a very big deal at all. There are children who are born with meningoceles that and their spinal tube is completely closed. It's just sort of right on the edge of it, and there's some fluid in there, and they can drain that fluid, and that's pretty much it. It just kind of resolves itself after that. However, sometimes there is an actual opening and injury to the spine because of it. When that is the case, there is typically paralysis below the point of the meningocele. So if you have a very low meningocele at the very base of the spine, you might need some braces. You might have some stuff like that. You might have some issues with constipation. And you may be not have a whole lot of effect at all. If it's a little higher on the spine, you might be paralyzed from the waist down. If it's even much higher, you could have quadriplegia, just depending on where that meningocele takes place. Again, just like CP, having this physical disability does not mean that there is intellectual involvement. There are people with spina bifida and cerebral palsy who have completely typical or even sky-high intelligence IQ. There are certainly people with both CP and spina bifida who additionally have some other types of brain injury or other types of developmental and cognitive delay or disability. They just don't all have it. It's very important that you do not assume that because someone has a physical disability that there's necessarily intellectual disability to go with it. We will talk about, in just a minute, we'll talk about things like crutches and walkers and things like that. But certainly people with cerebral palsy, people with spina bifida, oftentimes use mobility devices, and we'll talk about those in just a second. Another disability I think that we ought to talk about related to tone, or at least want you guys to have in mind that when we talk about muscle tone and issues with muscle tone, certainly students who are in chairs and students with cerebral palsy and students with spina bifida are not the only ones affected. Some other common disabilities that are usually considered developmental disabilities that sometimes are comorbid with some tone issues are autism. Lots of students with autism have very high tone in their legs. You see toe walking, which may start out as sensory, but they can actually shorten those muscles and have develop contracture in the muscles and in the joints. So it's very important to make sure we stretch those and deal with that tone issue so that it doesn't become a permanent physical disability that started as a sensory issue caused by toe walking. Down syndrome. Students with Down syndrome have very low muscle tone usually. We have to work to build up their tone to make them stronger so that they don't dislocate joints, they have less pain, and their bodies are easier to move around and keep them physically fit. Anytime that there's any other sort of brain injury, you can have tone issues. My daughter has, she has a condition called Ehlers-Danlos syndrome. It's an insufficiency of all the collagen in the body. So all of her joints are very, very lax because her connective tissues, like tendons, are all very, very loose. They don't work really well. That makes it harder for the muscles to be good and strong, and it makes it harder for her joints to stay in place. My son has a condition called arthrogryposis, which is a musculoskeletal condition that causes contractures. So where her joints are very, very loose, his joints are frozen stiff. I don't know how I got so lucky to have both ends of the spectrum, but we did. And so he cannot move anything below his knee. It doesn't move at all. He was born with bilateral club feet, and club legs and bilateral hip dysplasia. He has had multiple surgeries, and now his feet are fused into a position that allows him to walk. He does walk. He does run. He does jump. He does skip. Nobody told him he couldn't, so he did. But he does wear braces all the time. If he didn't wear braces, his bones would move right back into that unfit a position that would not allow him to walk at all. There's tone issues with all kinds of disabilities. Be on the lookout for them, but those are kind of the most common, and the ones I think you'll see the most would be spina bifida, cerebral palsy, Down syndrome. We also at least need to touch on hearing impairment and visual impairment. Hearing impairment means exactly what it sounds like. You can't hear as well as other people. It can mean total deafness. It can mean mild hearing loss. Of course, we can't go into everything, but frequently children who have hearing who are hearing impaired wear hearing aids. Hearing aids need their batteries. They need to be left alone. Lots of kids tear up their hearing aids. Lots of students, unfortunately, other students sometimes will be interested in them and break them, so keep your eye out for that. If you have a student who has a hearing aid and all of a sudden they're not hearing anything, ask them if it's on and make sure that battery's working. Hearing aids also have to be cleaned regularly. If you have a student and you think that they're not hearing quite as well as they are, as they had been, you may want to ask, is it time for them to be cleaned out? And see if somebody at home or somebody who knows how to clean them is able to do that for you. Couple other things to think about with hearing impairment, especially if you have a child who is having behavior issues or is referred to special education and they realize that they have a significant hearing loss and all of a sudden that child is wearing a hearing aid, please know that hearing aids almost always amplify all the sound. Not just the sounds that they want to hear, but all the background noises as well. And it is very difficult for a person who's used to hearing hardly anything and having to super concentrate on something to all of a sudden hearing every little sound. Their brain has to remember how to tune things out. It can be very discomforting, and it can always be to some degree a problem. So try to be sensitive to that. They may need to, especially someone who's new to hearing aids, may need to sit in a place where they're not surrounded on every side by things going on. There are cochlear implants for students who have conduction loss. It's a hearing device that's implanted into the skull, into the body, goes into the inner ear itself, and it conducts the sound in the ear of someone for whom sound wasn't moving through to create sound. Cochlear implants, pretty much all a teacher would deal with is making sure that they stay dry. They can be removed. That the outside part can be removed if you happen to be going on a field trip or doing something where a student's head might get wet. I would definitely talk to their parents because they might need to take off that outside piece like they do for a shower. Other than that, cochlear implants are there. They're amazing. Also, you should know that the deaf community, one, frequently prefers to be called deaf rather than hearing impaired. And that's okay. People get to decide what to call themselves. Two, many people in the deaf community consider sign language to be their first language or their child's first language. It is important, if that is the case, that you have someone who can sign for the child, an interpreter, and that as you learn signs, that you learn to do them correctly, and that you always use your facial expression, because to sign in American Sign Language, at least, or American Sign English, to sign without using your facial expressions to mimic what your words are saying is actually considered insulting. So it's very important that you know what you're doing so that you don't agitate anybody. And that you respect that that is an actual language. It's a valid language. It's a good language. And it's their language. And so even if they get an amplification device and they don't need sign all the time, it is okay for them to use it. It is okay for you to use it, and you absolutely should do so to help them. With visual impairments, again, huge spectrum. You can have somebody who things are pretty blurry for and they needed books with big text, or you can have someone who's completely blind. Very few people are 100% completely dark blind. So there are all kinds of visual impairments that involve visual field. So you might have someone who sees things right in front of them, but they don't see very well to the top or bottom. You may have people who can't see so much right here, but they might see down on the lower half, or they can see things better to their right side or to their left side. Students who don't have good peripheral vision, so they have a tunnel vision, or the opposite of that, where they're sort of blind through the middle, but they do have peripheral vision. And you will have students who have light discrepancy, and they can see movement, and they can see light and dark, but they can't see enough to read, for instance. And you can also have students who have cortical vision issues where there's not actually anything keeping them from seeing, but their brain is not unable to interpret what they're seeing. And all of those need to be dealt with in different ways. But some things that just to think about right offhand, you can use a slant board to put things at angles that are better for visual field problems. So if you have a student who has a problem in their left bottom quadrant of vision, remember those quadrants again, then you want to present their work to them in the top right. And you can put your slant board right there, and they should be able to see it pretty well over there. If you have a student who has peripheral vision and doesn't have front vision, you're not going to want to set very active children on either side of them, because that's going to be very distracting. That student is having to use his or her other senses to follow along with what you're doing. And so if you have visual stimuli going on like this in the only vision that they have, that makes that twice as hard. A lot of students who have visual impairments need high contrast. Some students do better with amber colored writing on black, or with white writing on black. Some students do better with bright colored paper underneath their paper, so that they are kind of helps them to keep their focus right there. So there are lots of tips and tricks, and really very, very individualized. So I highly recommend, if you have a student, you find out your student has visual impairment, that you really talk to their parents and say, hey, are they drawn to certain colors? Do they like certain things? Do certain things bother them? You're also going to remember to always keep your room very tidy, because a person with visual impairment could get hurt very badly if you have stuff that's fallen out on the floor. If you're going to want to give them a seat that's pretty easy to get to. You're going to want to reduce just the visual clutter of things. Some people we love to have bright colored classrooms with all kinds of stuff, all the students' artwork and everything all over the walls. And that can be really great, but it can be really overstimulating, especially to children with cortical vision impairment who have trouble interpreting what their eyes are seeing anyway. So they may need less on those walls, or at least where the board is, don't put a lot of things to the side of the board. Let the board be the focus of what they see, and then put some things to the back if you need to. Those are kind of the big disabilities that I think you're most likely to run into in your classroom. The other one that I hadn't mentioned is epilepsy. Epilepsy is technically anybody who has had 3 or more seizures in a lifetime outside of without a known other cause. So, you know, if you had a head injury and you got a concussion and you had 3 seizures that night, you don't necessarily have epilepsy because you know that it was caused by the head injury. However, if you have a seizure that the day that you get a concussion, and then for the rest of your life you have 2 or 3 more, you have epilepsy, and that's how it works. We do not know the cause of all kinds of epilepsy. We certainly have identified genes that cause it in some people, but the etiology of seizures is not known for more people than it is known for who have epilepsy. Seizures also can look very, very different. So I want to talk about some different kinds of seizures, and I want to talk about what you do if you see a seizure, and also what information that you as a teacher need to gather if you find out a student coming to your room has epilepsy. So the first thing I want to talk about is different kinds of seizures. I know that a lot of people, when you hear seizure, you think the person falls to the ground and they shake violently. They might foam at the mouth. You've heard all kinds of horror stories, and all of those can happen. And the truth is that kind of seizure is called a tonic-clonic or a grand mal seizure. And the truth is they're scary. There's no way around it. It is scary the first time you're around a grand mal seizure. And really, honestly, it's scary the 10th time you're around a grand mal seizure. They're just not pleasant to be around. For most people who have them, they are not painful unless they hurt themselves during it. And you should also know that just because a seizure looks really bad doesn't mean that it's causing more damage to the brain. The truth is a silent seizure can be causing much more damage, or grand mals can cause next to none. It just is about where the seizure is occurring in your brain. A seizure is basically an electrical storm in the brain. At some point in the brain, there's a short circuit and electrical activity occurs that is out of sync and not the correct brain pattern. And that causes what we call a seizure. In addition to what I just described, a jerking, heaving, body moving seizure, you can have what's called a partial seizure, where you do have movement, but it's only in part of the body. That's where you get into those quadrant discussions. Or there's a tremor. Another type of partial seizure might not have any tremoring at all, but a person's behavior might change. There are people who have partial seizures and they just start walking around, kind of wandering around. But when they're done with their seizure, they don't really know that it's happened. You have people who just start talking, and what they're saying doesn't make sense, and they seem very disconnected. That's a partial seizure. The language part of their brain is ignited by all this activity, but it's not intentional speech. It's just happening. It's a kind of partial seizure. There are people who have absence seizures, which is and a lot of times people call those staring or silent seizures, which you could totally miss. But if they weren't talking or doing something ahead of time, they just all of a sudden they look like they're kind of far away. There are people who can talk to you during an absence seizure and still be having a seizure. They won't remember what's happened when they've gotten up, or when it's over. The period after a seizure is called a postdictal period. Just means after the seizure. A lot of people, regardless of the kind of seizure that they've had, a lot of people who have had a seizure, they're tired. They may need to sleep. They may need to lay down. They may have a headache. They may be confused. They may be none of those things and pop right up and it's like nothing ever happened. Also know that people who have seizures sometimes they do drool. Sometimes they get nauseated. Certainly not often or always, but some people do. Sometimes they lose bladder or bowel control. That might be something, especially if you teach middle school age or high school age students, to be very aware of. If that happens with a student, want to make sure that they have something at school that they can change into, and you want to be very active in that case and making sure that you're getting the students away so that they're not embarrassed by something that's not in their control. There's one other kind of seizure that we need to talk about, and that's drop seizures. In a drop seizure, the person falls. If they're standing, they'll fall to the ground. If they're sitting, they might fall forward or even slam forward very quickly. If you know, a lot of times people who have drop seizures wear helmets, not always. If you know that a student that you work with has drop seizures, that's something you're going to want to be very, very aware of. And you're going to have to stay close or have someone who does stay close to help protect them in the case of a fall. So seizure myths. I'm going to tell you exactly what to do if there's a seizure right now. Please don't do anything but this. If a student is having a seizure and they're sitting up and not falling over, just stay close to them and make sure they don't fall over. You can talk to them in a reassuring voice. You can pat them or rub their back if that's something that the student would like when they were awake. You certainly can do that during a seizure. You don't have to. But you do want to time it. With any seizure, the moment you recognize a seizure has happened, begin timing it, because the length of a seizure determines how much damage it can do. If a student is having a tonic-clonic seizure, the big jerking kind, the best thing to do is to put something under their head and move them slightly to the side if you can, easily. If you can't, leave them alone and roll them to their side as they come out of it. Always talk in a calm, reassuring voice. Many people who are having seizures are aware of your voice, and hearing that voice can help their brains to kind of refocus and have that and get that energy out of control. Do not try to hold down someone who's jerking around in a seizure. Holding them down can actually prolong the seizure by not letting that electrical energy and impulse get out of the body. It sends it right back up there, and it's going to keep that loop going. So let that body move. You do want to protect their head, so put something soft under their head, a blanket, a jacket, or even your hands if you need, if you're out on the playground and their head's going to hit a rock, use your hands. That's okay. But you're going to want to let the rest of their body move as it needs to until they're finished with the seizure. Do not put anything in their mouths. Putting anything in the mouth of a person having a seizure absolutely puts them at risk. There's an old myth that says that people having seizures can swallow their tongues. That's not a thing. You can't swallow your tongue. Your tongue's a muscle and it's connected to your mouth. It cannot be swallowed by your body. I said before that you're going to want to time the seizure because that's exceptionally important as well. And now I'll tell you why. The truth is, seizures are individual to the person that has them. There are people for whom normal is that they have a seizure every day, or 10 seizures every day, or 20 seizures every day, and that's their normal. If that's their normal, it's okay. You don't have to panic if they have 20 seizures because that's their normal. Their family knows they're normal, their neurologist knows they're normal, and they've shared it with you. There are other people who have generally good seizure control, and any kind of breakthrough seizure is something that causes an immediate call to the doctor. So you need to know what is normal for that child, what their seizure usually looks like, how and when the parent wants to be contacted. Is it someone who, and you need to know what to do. Is there a rescue protocol? If you know that a child has seizures and they have a seizure that is different from the kind that you know is their normal, automatically contact the parent. Okay, so we've talked about some of the disabilities that you might run into in your room, and now let's talk about some of the things that you might deal with as a result of that. The first one I want to talk about is bracing. Braces basically are used to do one of two things. They're either used to immobilize something. So if you have a joint that's too wobbly and something wants to go out of place, you might use a brace to hold it in place. Or if you have a spine that's starting to curve because you have scoliosis, you might use a brace to hold that spine in the right position so that it continues to grow straight instead of continuing to curve. Or you might use bracing to offer support. The most common kind of bracing are SMOs and AFOs, and I have some here to show. These are SMOs. They're short. They go basically from the ankle and into the shoe. As you can see, there is some rigid plastic as well as some supportive inside. There's a left and a right. This one has a little sticker to mark it. These stickers don't stay on very long, so when your kiddo first comes to your room, different braces do it different ways, so pay attention to when they come in with their SMOs or their AFOs on, pay attention to where the little brackets are, because that will help you know that they're on the right foot. You can't always tell very easily by the shape, and you can rub a blister if you have them on the wrong one. So the thing that never changes is the little bracket parts or the little closures will always be on the same side. So for this set of braces, which is one of my daughter's sets of braces, for this set of braces, the little metal pieces that we run the straps through go on the outside of the foot. So to put her foot in here, you open this up slightly with your hand, slide the foot in, then you, with her foot inside, you pull the strap, the Velcro strap. Oh, hang on. My Velcro's all tangled up. So you put the Velcro through and you pull it across, and you want that on. You don't want to pull it super tight so it squeezes the foot, but you want it on tight enough that their foot doesn't move up and down and slide around in there. One of the most important things whenever you're using any kind of foot and ankle orthotic of any kind is make sure that the heel goes all the way back in that shoe. If their heel is not resting on the back, the heel of the AFO, their foot is not in the right position, the brace will not be as effective, and they're at risk for getting a blister or some other kind of pressure wound. It is an AFO. It goes, you want it about an inch or two from the knee joint all the way down the leg into the ankle. There are lots of different kinds of these that look lots of different ways. This just happens to be Miley's, and she happens to be taking a nap, so I can show it to you. But it works very much the same way, same precautions. The other little things to look for. If a child gets new AFOs, if they go to the doctor and they show up at school for the first day in their new AFOs, every 20 minutes to an hour, pull those off. If you see a spot that is very red, leave them off. If that spot is still red after 20 minutes, contact the parent. They may need to use some moleskin or something, or have the braces refit. This is important when braces are new, but also as kids are growing. When there's broken skin, immediately take the braces off, use a Band-Aid, call the parent, and see how they want to handle it. But if it's just a red mark and it's not broken skin, leave them off for 20 minutes. If it's still red, go ahead and contact the parent and ask if they want you to leave them off or if they want to check it out when they get home. But the next thing to talk about is wheelchairs. All kinds of wheelchairs. And obviously every wheelchair is a little bit different. There's a little bit of a learning curve with everybody. who uses one, but there are some standard things that we can talk about, just so you know, so that you're not starting from nothing if you get a child with a wheelchair. So one thing is brakes. When a wheelchair is stopped, when you're not actively moving the wheelchair and the student is not actively moving the wheelchair, put the brakes on. It's a good habit to get into. The truth is, in your classroom, will they probably need those brakes on? Probably not. But if you go on a field trip and you're not in the habit of putting those brakes on, or if you're out on the playground and you're not in the habit of putting those brakes on, and the student's on a hill, they can start to roll away from you, and that is not a good feeling. Another thing that you should know is anytime you're using a wheelchair for a student, you want to make sure that their back is pushed all the way to the back, because that is a wheelchair is set up, it is fitted for a student to have their, or adult, to have their back flat against the back, including their behind flat against the back, and for their feet to be in the foot pedals. Some students need their feet strapped down. Some students don't. Some students cross their legs. All of that is okay. It's their legs. They can do that unless you're otherwise notified by the parent or the PT that that doesn't work for that child. But when you put them in the chair, make sure that their back is against the very back, that their bottom is in the chair, that their legs can reach the pedals and can sit flat. The only, other than brakes, and making sure that they're in their seat appropriately, the other big thing for having a kid in a wheelchair in your room is make sure that you have wide access. You need to really simplify the furniture in your room. I know we all love to set up center areas and neat little nooks and that kind of thing. That may just not be the greatest option while you have a student with a chair in your room. Or if it is, you may have to really think about how are you going to set up that nook where you're not creating a big obstacle that is not worth it for that student. The other thing to think about whenever you have a student who uses a wheelchair or has any other sort of tone-related disability, positioning matters. Positioning saves lives, and it ends lives. So, for those of us who have sort of typical body movement and ability, if our heinies are getting sore, we wiggle in our chair. And because the weight of our own bodies on our bones and on our muscles causes fatigue, and our body experiences a little bit of discomfort, maybe not even enough that you notice, but some, and we shift. So, but if we are strapped into a chair where we can't move our feet, we can't move our legs, we've got a lap belt on, we've got a harness on, we've got our feet strapped down, you can't move. Or if there's any degree of paralysis, you can't move. Or for some people, there's sensation differences. Whether or not they're paralyzed, they can have differences in sensation, and they don't feel that fatigue, they don't feel that discomfort, and they don't move often enough. And that is how people get pressure wounds and pressure sores. It's the weight of our own bodies, our own organs, and our muscles, and all of those things against our bones, and our bones against them can actually cause sores that can cause breaks in the skin. We call them bed sores, pressure wounds, skin breakdown, and they are not only horrifically painful and utterly unnecessary for anyone to get them, but they can be fatal. If you think about if you know who Christopher Reeve is, back in the 80s, Christopher Reeve played Superman on the movies, and he was a big deal. And he was injured in a horseback riding lesson, or horseback riding activity that he was doing. I think he was doing a steeplechase. He was thrown from his horse, broke his neck, became a quadriplegic. one of the wealthiest quadriplegics in the world, had the best care, but developed a pressure wound. At some point, his pressure wound became infected. The infection spread to his blood system. He developed sepsis and he died. Positioning and pressure wounds killed Superman. Take it seriously. You should move a student in the chair, not necessarily out of their chair every 20 minutes, but their position has to change every 20 minutes at least. Even if you move them in their seat every 20 minutes, you can't stay in them. Nobody should stay in a seat 24 hours a day, 7 days a week, or even 6 hours a day at school. So you're going to need at least 1 to 2 other, no, you're going to need at least 2 more positioning opportunities for them in your classroom. So probably the most common one is a stander. Standers look all different kinds of ways, but basically they do exactly what they sound like. They help someone stand. Standers can be used to strengthen the muscles so that hopefully a student will be able to walk someday. But even if they're never going to walk, even if they're a senior in high school and they've not walked yet, and we don't think they're going to walk ever, a stander it serves lots of purposes. In a body that's still growing, putting weight on the limbs allows that bone to grow properly. So, too, of course, if there's a chance that we're going to be able to strengthen those muscles and that student's going to be able to stand on their own or stand supported, that would be fantastic, because eventually they might learn to do their own transfers. They might be able to walk someday. That's another great reason to use a stander. But this one is the killer. This one is the big one. It's the most important one of all. Straight standing bodies clear airways. The leading cause of death for people who are in wheelchairs or who are fully wheelchair bound is pneumonia. It is lung deficiency, lung infection. Standing takes all the pressure that's sitting. When we sit, especially if we sit with low tone and our body kind of curves in, or if we're tired and our body curves in, we're compressing our lungs. They're not able to open to full capacity. We'll stop using them to full capacity, and infections become more and more likely. So when we're standing, our lungs are open to full capacity. We have a chance to take a nice deep breath. Those full breaths of full air help to keep the lung passages working like they're supposed to, and they lengthen the lives of people who are in wheelchairs. It is important to do. There are all kinds of specialized seating. There are feeding chairs. There are height right chairs. There are activity chairs that can be put in all kinds of positions. And those are great if you have them. They're fantastic, and I highly recommend them. If you don't have them, it's not the end of the world. Life moves on if you don't have a $4,000 piece of seating equipment. Other options that are cheap and easy to get and don't take up a lot of space. One of my favorites positioning devices is a beanbag chair. Lots of high tone and low tone students can utilize a beanbag chair to get off of the same parts that they're in their wheelchair in. You can use a beanbag chair to put a person on their who has good enough core control to control their head. You can put them on their stomach on a beanbag and let them write and do things that are on the floor in front of them. They're going to get some weight bearing that way. They're going to give their back a break, their hind end a break. And it's a different way for them to move around and function. Then some of our students who have physical disabilities need adaptive riding equipment. In general, There are students who can hold a pen or a pencil if it's adapted, and there are students who can't. If a student can't hold a regular pen like this one, there are grips that you can use. You can, lots of parent-teacher stores and things like that have them now. You can buy them for about $1. You slide them on the pencil, and it shows your fingers where to hold. Some people need much larger than that. You can make these. You can make salt dough and have the student grip it in the way that their hand would hold it, and then take the pencil or the pen, whatever you've stuck salt dough on, and let it sit and let that dry, and then they have a hard one. Or you can use modeling clay, which is much harder. It's not as soft. It doesn't pick off. It doesn't fall off and get squished in their clothes as easily. But old-fashioned plasticine modeling clay, put it on there, and it will always mold to their hand. And it can widen the pen and make it usable for them. You can certainly buy expensive adaptive pens, ones that can wrap around a wrist, ones with special grips, and those are fine. They're probably great, but just know that you can adapt something without necessarily buying the fanciest tool or a $45 pen that runs out of ink by the end of the year. Another thing that helps a lot of people, especially people with tremors, whose hands might shake as they are trying to write, is a weighted pen or a pencil. You can buy weighted pens and pencils again, but a lot of people have a lot of success with just buying a nut or a bolt and sticking them using tape, or some of them will just fit right down on a pen or a pencil, and it just weighs that down. That little bit of extra weight helps to stabilize the hand. It helps the hand get more feedback for where the pencil is on the page. Now, as you go up the spectrum, if they're unable to hold a modified pen or a pencil, the next thing that you're going to look at is some sort of, is can they type? There are people who can't hold a pen, but they can type on a keyboard, no problem. There are also adaptive keyboards. There are keyboards with bigger letters. There are keyboards for people with visual impairment that type Braille, or have Braille and type regular letters. There are keyboards that have high contrast letters so that they're easier for them to see. There are keyboards with bigger keys. And there are programs that allow you to type using pictures that will type words. And finally, there are keyboards that you can use, or computer programs that you can use with an eye scanner, where you can just use the direction your eyes look in to select words to type. So there are lots of ways to allow people to write that don't utilize their bodies in the same way. And if you need those, I highly suggest that you get online and look. What is available for assistive technology now is astounding, and it gets cheaper all the time with things like iPads and tablets. Touchscreens are no big deal anymore. They used to be such a big expense. Things are all the time. Things are more portable. They're easier to get a hold of. They're not so out of reach. So absolutely, don't leave someone with no voice because their fingers don't work. That doesn't seem to make sense at all to me. So the last thing, as far as equipment that you might run into your in your classroom, that I want to talk to you about is feeding issues. Of course, just like adaptive pens and pencils, there are weighted spoons, there are weighted forks, there are forks and spoons that have toggles so that they always even out so that you don't accidentally dump things. There are curved spoons, all of those things. But there are students who cannot eat by mouth, or can't eat enough by mouth without some help from a gastric tube of some kind. So we're going to talk about them next. As I was saying before, there are students for whom it's impossible to eat or by mouth, or to eat enough to grow and thrive. And that can happen for a couple of different reasons. There could be some tone or muscular issue that makes swallowing unsafe, so that students are choking or inhaling food or liquids into their lungs. That's called aspirating. There are also students, my daughter would fall into this category as well. She has gastroparesis, which means her gastrointestinal system runs very, very slowly. Another word for it is delayed gastric emptying, which basically means that her stomach can't ever hold enough food to keep going. She eats a few bites. Instead of her stomach expanding like it's supposed to so all the food can go in, her stomach stays really small, and then the food that she is able to eat in there stays a really long time, and she literally cannot eat enough food to grow. So she has now she has a gastric tube. But usually if they think it's going to be a short-term issue, or sometimes to get people used to having food in their system again who go a long time without it, doctors start with something that looks like this thing flapping around. This is a nasogastric tube. There's a wire in here that gives this a little bit of resistance. Otherwise, this would be very difficult. But you insert it into the nose, the nostril. Obviously, this one is not going to get used. You insert it into the nostril and you continue feeding it. You feed it down the back of the throat all the way into the stomach. Once it is in the stomach, you remove this wire so that it's very, very soft. I've removed it partially so you can see that it's, that makes it very, very soft. So it can move with their body as they are moving. And you use some tape, like this Hypafix tape, to tape it. You let it come out of the nose. We're going to pretend this is in my nose. I'm not dry. I love students and I love teaching, but I am not dropping a nasogastric tube so that you all can see how this works. But we're going to pretend that this is down in my stomach, and then we would tape some of the last remaining bit to the face right here. After that is done and you remove this wire like this, then you can come in and you can feed a person through the end of the tube. That, this is out here. Actually, it would be more than that out there, but it's out here somewhere. And you take, you're able to feed with that. Now, some people can do what is called a bolus. That means that you give all the food at one time. Preferably, if you do a bolus for someone, you are able to feed it by gravity. It means exactly what it sounds like. You will take a big syringe. This is a 60 milliliter syringe. It doesn't have a needle. It goes into the receptor tip of the NG tube. You pour formula or blended food or whatever, or Pedialyte, whatever kind of fluid or medications for that matter that the person takes. You pour it into this tube, and hopefully you can use gravity to let that go in. Whenever you can gravity feed, it's best to gravity feed because there's less chance of getting it in very fast and making somebody feel yucky and nauseated, and also much less chance of injecting a bunch of air in there. You can imagine what it might feel like to have a bunch of air shot into your stomach very forcefully. It's uncomfortable, and we don't want to do that to people if we can help it. However, sometimes kids with gastroparesis are famous for this. Their bellies don't want to take anything, and it has to go in. We have to have seizure meds whether her belly wants to take anything or not. So in those cases, you may have to use the stopper and push meds. After you've given all of your food or all of your medication or all of whatever you're giving them through their tube, which is prescribed by a doctor, by the way, it has to be prescribed by a doctor. But once you've done all that, you will need to put water in. Do not just pull this out with it in here, because if you do, everything you just put in their stomach is coming back out with it. So always want to flush it with water. If you don't flush with water, your tube will become blocked. You won't be able to put anything in it, and you'll have to take it out and put a new one in. The other thing that you need to know about using a nasogastric tube, this is exceptionally important. Unlike a gastric tube or a G tube or a GJ tube, a nasogastric tube is flexible and temporary. They can move out of the spot they're supposed to be in. If somebody coughs, if they wiggle just right, if they gagged a little and you didn't know about it, for whatever reason, if the moon's shining just right and bad things happen, this little tube can very easily move out of the stomach where it needs to be and either be up in the throat where it can be aspirated into the lungs, or it can actually go into a lung. So before you ever put any fluid in a nasogastric tube, ever, whether it's before when you first place it, which teachers shouldn't be placing these. If a nasogastric tube comes out, they're a temporary thing. Call the parent, have them come in, put it back in. Call a nurse, call a doctor, call whoever. I can't think of a reason that a teacher would need to be the person placing an NG tube. But whether it's just gone in or there's been any kind of pause in the feeding. So unless a child is pump fed and you're just going to push some meds through here while they're already being pump fed, you absolutely, every time, you have to check to make sure that it's in the place it's supposed to be. The foolproof, the 100% way to know is to pop a syringe in the end of your NG tube and pull back and make sure a little bit of stomach fluid comes up here. If you pull it back and nothing comes up, you need to take the tube out and put it back in. That's an NG tube. If it becomes obvious that a patient is going to need feeds over a long period of time, an extended period of time, usually the family and the doctors decide they don't have to. You can live your whole life with an NG tube. But usually, because it's safer and because skin starts to break down when it's got stickers on it, tape on it all the time, and it's just fairly unpleasant to use these. Next, they usually use a surgical option. They can do this a couple of different ways. First of all, the two options for a surgically placed tube are a G tube and a GJ tube. A G tube stands for a gastrostomy tube. It is a hole in the stomach that they put some sort of catheter in, and you can feed fluids, whether that is a blended food diet, a formula, some other, just liquids if somebody can't drink enough to keep their body hydrated. Some people just get water or just get Pedialyte through their tubes. So medications, whatever needs to go in the stomach can go straight into the stomach. A GJ tube is a gastrojejunum tube. It goes straight into there are some people for whom the stomach is not functional at all. The stomach doesn't work. Their body doesn't absorb food from the stomach, or it empties so slowly that it actually food rots in their stomach before it gets emptied into the jejunum, into the small bowel or small intestine. So they run the tube. It still is close to the same place, but they run the tube actually into the intestine instead of into the stomach. That would be a GJ tube. Either way, they work pretty much the same. You usually once you've had the permanent surgery, you will either have a long tube that hangs out and you have to use tape or something to hold the tube down when you're not feeding. Or many people choose to have a button. This is what my daughter has. This one is too small for her, and I use it to train anybody that works for us. So this is our, this would normally be inserted into the skin. She has a hole in the skin of her stomach, of the outside of her stomach. The hole actually goes through to her actual stomach. The opening of the skin is called a stoma. This device goes into it. You would stick this in her stoma. If her balloon in her GJ or G tube pops, or if it stops working, this little thing, then we just replace it. So we can do that part at home. Once it's surgically placed, the rest of it you can do at home. Believe it or not. Sounds scary, but it's not. Okay, so here's our little Mickey tube. And we would put this in. You know, if hers came out and we had to replace it, we'd stick this guy in. We have 5 mLs of water. We inject that in there. While this would already be in her stomach at this point. And this little balloon with this little bit of water in it is what, oh, well, you got to hold it. There we go. So this little balloon with this water in it is what holds it and keeps it from coming out of her stomach. And that's about how long back then. It's a little bit longer now. But back then, this is about how long it was from the outside of her stomach to her actual, or the outside of her skin to her stomach. And food goes right in here. I can finish that off in a minute, but then we put food in to here and it goes straight into the stomach. As you can see that kind of coming out. Goes in, there's an extension that goes from the belly that you put in here, and into the extension you could do this, like we talked about with a bolus. This is how we give Miley's medicine. Medicine goes into, you know, we put the extension into the catheter, which I forgot to bring in here, and I apologize. But there's an extension that goes into here. This plugs into the extension. We put the medicine in and gravity takes it down. We flush it with water. We close it up. However, because Miley has the gastroparesis that we talked about, which means that her belly doesn't empty quickly, she can't tolerate big bunches of food. She can't tolerate a bolus. It would make her very, very sick. So she uses a continuous feed pump. Now, I'm not starving her right now. She eats 14 hours a day. So she is on her break right now, not starving. Pretty simple little machine. I mean, like super simple machine, basically. There's on off. The parent would probably set the rate. You probably wouldn't have to mess with that. If you do, it's very, very simple to move the rate up and down. The only other thing that I really want you to know is when you are going to feed somebody using a feeding pump, you put liquids in the bag, whatever amount is prescribed for whatever amount of time. You need to make sure that you get all the air out. If she's going to be walking around, she uses a backpack that is made to hold her pump and her feeding bag. If that's the case, if she's going to be using that backpack, before I can hook her up to that, I have to turn this bag upside down, squeeze out any air, and release it through the tubing, either using that prime button or manually, and make sure there is no air in that bag, or else we will get bubbles and it will beep and fuss at us all day long. Gastric tubes, G tubes, NG, gastric tubes, J tubes, they're not a big deal. They're so not. Usually kids can be taught to do a lot of the steps themselves. I encourage you to always do that if you can. There are things about them that are uncomfortable that are much more comfortable if they are able to do for themselves than they are to have someone else do for you. But don't let a G-tube scare you off. Or the other thing is, a lot of people worry about, oh, what about the stoma? What do I have to do to take care of the stoma, which is where the tube goes in the skin? The best thing you can do for the stoma is leave it alone. If you scrub on them too much, if you're messing with them too much, you're much more likely to put bacteria there or wipe off the good fighting stuff. You want them dry. So if you're seeing that there's some leakage or some oozing, you might use some Mepilex or gauze, whatever works for the student. That would be something you would talk to the parent about. Otherwise, leave it alone, And always, if you're changing someone with toileting or if you're doing feeding of any kind, even if you're just feeding someone by mouth, you need to use gloves. Universal precautions are important for everybody. They protect you should the child have something communicable that they could give to you, but you also are protecting them. If you have a flu, if you have germs, or if you have something that you're unaware of that's more dangerous than that, you could pass it to them straight into their mucous membranes in their mouth. So anytime you're doing feeding, whether it is by G-tube, J-tube, by mouth, or if you're doing changing and helping with toileting, you always want to use gloves. And it's pretty simple. If you remember nothing else that I've told you today, remember positioning saves lives. The next thing to think about is language precautions. Just like I was saying, you don't want to call someone with CP someone with spastic CP. It's CP with fluctuating tone. CP. Just when you talk about anything, when you're dealing with the intimate care of another human being, if a student needs help with toileting, if they use a catheter, and they need some help with that, if they use a diaper and you have to change that, this is a school-aged person who may, because of a physical disability, not be able to toilet independently. You need to respect in their language that they're human with dignity. Don't make jokes about smell. Don't talk about changing them out in front of their peers. Nobody wants to talk about going to the bathroom in front of their peers. Respect privacy and remember to think about how you would feel if you were injured tomorrow and all of a sudden you could no longer go to the bathroom on your own. How would you want people to talk to you? How would you want people to treat you? What kind of privacy would you expect? Also, always, a student may have something that's very visible, that it's plain to see that a student in a wheelchair is in a wheelchair. And sooner or later, somebody's going to say to you, what's wrong with that kid? Or what's his diagnosis or her diagnosis? And the fact is, as their educator, it is not your place to tell. And the correct answer to that question is, that's a confidentiality issue. And I'm not able to discuss that. You're welcome to ask him or her parent. But that's something that would have to be a parent decision whether or not to give you that information. It may not be the warmest, fuzziest thing to do, but it's how it is. Now, and also desperately important is what we call the least dangerous assumption. I had touched on it before. I'll touch on it again. I will touch on it until the day I die. It's my favorite soapbox. Physical disability does not equal intellectual disability. And even if there's a known intellectual disability, it is not okay to assume that a student doesn't understand or doesn't get it. It is not okay to assume that a student who is nonverbal doesn't understand what you're teaching them. They may not be able to tell you what they understand, but you should assume that they understand it unless they demonstrate that they do not. If they demonstrate that they don't understand it, then it's your job to figure out a way to present the information so that they do. Until you have provided them a way to demonstrate that they don't understand, whether that's with picture communication, whether that's by allowing them access to physically touch things and show things, or to use eye gaze or assistive technology, however you want to do it, until you have offered them a surefire way that you are sure that they can physically respond with to let you know that they understand something, and they've demonstrated that they didn't, you need to assume that they do. Assume intelligence. Assume understanding. 9 times out of 10, maybe in my experience, 100 times out of 100, people with whom I have worked who have limited or no verbal ability understand far more than they can express. And given opportunities and ways to communicate, they will start to do so. So, the last thing I want to leave you with is this. I want you to imagine that tomorrow you and your classroom are getting ready to do a really cool STEM project that you all have worked on. A really neat science, technology, and engineering math unit that you all have been working on, and you've done this big display, and everybody's set to go, and everybody's real excited, and the principal gives you a call and says, Mr. or Mrs. So-and-so, I just want you to know we got a call from the caregivers of a person today. That person is really interested in STEM, and they asked if it would be okay if he came to the event. Just wanted to let you know that he'll be there, that he'll be in a wheelchair. According to his caregivers, this person is nonverbal. He can't eat by mouth. He makes very little facial expression. He's completely paralyzed and unable to move and uses a ventilator. But he'll be there tomorrow. Really likes STEM. Please make him feel welcome. And you say, great. So I want you to think about in your mind how you would handle that, how you're kind of thinking about addressing this person and his caregivers, how you're thinking about making sure that he can get in and see what you're doing and how he could be a part of it or not. And then I want you to imagine waking up the next day and going to school and getting ready to do your project, and the principal waves you over and calls you over, and the person who uses a wheelchair, who doesn't toilet independently, who doesn't talk, sometimes drools, and can't eat, is Stephen Hawking, who is a internationally renowned physicist and a Nobel Prize winner. And he really likes STEM, and he's come to see your project. It's important to remember that physical ability does not equal intellectual ability.